I just see Marcia said that she can't accept the passcode. If someone could just text her that it's coffee with a capital C, that's sometimes a problem. So thank you so much for joining us for our first 2021 Coffee Club. We truly are so excited to have a talk in the next talk in our medical series. We've had some really fascinating talks in our medical series. We've heard from a heart transplant patient and a kidney transplant donor. And today we truly are very honored to have Dr. Gary Reubenson join us. When we asked Gary to speak, we felt that the topic of COVID and children is so top of mind at the moment, especially with all our children going back to school during the second wave, or more near the end of the second wave, and there were so many questions that were asked. So I'm just going to give a short introduction. Well, I'll give a short rundown of how today's Coffee Club is going to run, because it's a little bit different than previous. And then I'll introduce Gary and hand it over to him. So this particular Coffee Club, we would like it to be a bit more of an interactive questions and answers Coffee Club. So Gary is going to give us his talk, and then we will open the forum up to some questions. I did indicate on the WhatsApps that if anybody is shy or wants to ask something anonymously, they're more than welcome to either WhatsApp me, or they can direct message me on the Zoom, and I will put the questions to Gary. I've also got a few questions that I've collected this week that I'll put to Gary. And we did not forget, one of the most exciting parts of our Coffee Club is our prize. Our mystery prize is up for grabs today. The way that it works, like every other Coffee Club we've had, is that at the end of the session, we would have made a list of all the members of all our participants, and this week it would be Aideen, possibly Michaela. Will draw a number, and that would be our winner. I'm going to leave the prize as a mystery until the end to make sure that you all stay. So without further ado, I'd like to introduce Gary. Gary Reubenson is a pediatrician with a subspecialty in infectious diseases. He works at the Rahima Musa Mother and Child Hospital. I'm sure that there are several degrees after his name, qualifications. He's very humble, and he didn't send that to me. So Gary, I'll hand over to you. Just thank you for your time, and please go ahead.
Thanks, Noah, and it really is great to be chatting to everyone. And as you said, I do want this to be as interactive as possible. I really would like people to make sure that they leave here having the questions that they want answered actually answered, and I'll try and do that as best I can. So firstly, the question I asked myself, well, why me? So as Noah said, most of you probably know me best as Aideen's husband, in that she's with Noah, one of the co-organizers of the Coffee Club. So those of you that are regulars will have seen her here fairly often. Hopefully by the end of the session, I'll have convinced you somewhat that there's a little more to what I have to offer than that just being her husband, but there are worse things that I could think of to be called than Aideen's husband. By way of background, when preparing for this talk, I've kind of thought, well, and as I'll show you in some of the slides, if COVID really largely spares children, why has the last year felt anything but like my life was being spared with respect to COVID and the various aspects around it? And so what I decided to do, just kind of in preparation for it, was to just look back through my kind of the COVID-related things that I've been involved with over the last year, and just kind of take a little snapshot of what they've involved, and yeah, and these are the various things that I could find on my computer that I've been involved with and contributed to, related to COVID, largely pediatric, but not only, and it cuts across some institutional guidelines at the places I work, contributing to certain provincial things, national documents, particularly with respect to interventions, largely treatment and medication interventions, a couple of other publications around just describing our experience, and also through the South African Pediatric Association, putting out a couple of position statements, which some of you might be familiar with, but if not, we'll potentially touch on along the way. So kind of the structure of this is going to be just 3 or 4 slides, just really giving some background, which I'm sure will be familiar to almost everybody who's listening in, around COVID in children, and particularly how COVID is different in children compared to adults. So just a couple of stats just to start with. And when I'm talking about children for the purpose of this talk, I'm talking about everyone up to 20 years of age. Certainly that doesn't describe the population I'm looking after. As you'll see in the next few slides, the vast majority of the people in the under 20 age group that have been affected are in the 15 to 20 year olds, 15 to 19 year olds, which is not a group that really access pediatric services. But for the purposes of many discussions around COVID, they're often included in there. So as of earlier this month, the children up to the age of children and adolescents, so people up to the age of 20, based on 2020 estimates, constituted about 37% of the total population of the country. And so that means well over a third of all the people living in South Africa are under 20 years of age. So that number's just under 20 million people. Now, when you look at the age breakdown of confirmed cases of COVID, so those that have tested positive, people under 20 years of age make up only 9% of confirmed cases. So already that's only a quarter of the burden of disease that you would have predicted if you simply were expecting the disease to affect everyone equally. And then when you kind of drill down a little bit further, only about 3%, sorry, just under 4%, 3.7% of all people admitted to hospital, cutting across public and private sectors, are under 20 years of age. So we're now even a third less than that. So we're only at 1/10, roughly, of what the admission rate we would have expected, again, if the disease affected children to the same extent they affected other people. And then when you look at COVID-related deaths, the children and adolescents, everyone under 20 years of age, makes up just over 0.5%, so just over 1 in 200 of all the people that have been documented to have died in South Africa while infected with COVID, are under 20 years of age. So it really, for reasons we can touch on if people are interested, and reasons which we don't entirely understand, largely spares the younger age groups. And just to show you that in a little more depth here. So this is just a graph looking at the incidence over time of confirmed COVID cases in South Africa. The dotted line is the country average, and it won't come as a surprise to anyone, but older adults, so that's the 20 to 50 to 40 year group, 40 to 60 year group, and above 60 make up the vast majority of those cases, and children make up a much smaller proportion. And of those people that are under 20 that are affected, the majority of those are in this line here, which is the 15 to 19 age group. So the true pediatric population. So when people talk about pediatric populations from a medical point of view, that cutoff varies, but it's seldom above 14 years of age. So if we were to use that cutoff, as you can see here, it makes up only a tiny proportion of the total cases in the country, and we're no different to every other country that has this sort of data. Just show that kind of demonstrated another way. Here you can see This is broken down by age and by sex. And again, looking at this is up to the 6th of February, looking at the burden of disease across age and sex categories. And you can see again, much smaller numbers of laboratory confirmed cases in children than in any other age group. And again, considering that a third of all the people in the country would fall into those categories there. Again, showing you much the same sort of thing here. This is this is looking at incidence risk by age group, but it's corrected for population size, and exactly the same pattern remains. Moving on to look at admissions and deaths, and these are not necessarily countrywide, but these data for the best quality data we have around admission and death in the country are from particular hospitals which contribute to it. And again, same sort of thing you're seeing. Overall, in the best part of a year, around about 9,000 admissions, well, in the under 20s over a year, compared to hundreds of thousands in the cumulative adult population. And when you look at deaths, a couple of hundred children. Obviously, each one of those is a tragedy, but only a couple of hundred deaths compared to well in excess of 50,000. And this last slide before I kind of open it up for questions is just really a snapshot of our hospital's activities. And again, it shows the same sort of things. We're a mother and child hospital. Almost all the testing that takes place within the hospital is that of children. We test every child that we admit. We test every caregiver who's accompanying a child that requires admission. And like any other kind of graph that's looking at the disease in South Africa, you've seen the initial peak and then flattened out, and then the current peak, which again seems to be flattening out, and again really small numbers, and we're doing quite widespread testing. So that's all I'm going to kind of say by way of background, and yeah, very keen to take whatever questions you've got, and everyone that talks on COVID, one of the kind of disclosures they make right near the start is that none of us can be considered experts. We all do the best we can, but this is certainly a very humbling disease in that whatever we think we know, there's a fairly good chance that within the near future it's going to change. So I'm happy to answer the questions that come up, and with the proviso and understanding that that same question asked a week, a month, or a year from now might well have a very different answer. Okay, I don't know, Noah, if you want to, if you've got questions there. I don't see, on the view I've got, I'm not actually seeing people with hands or unmuted mics. But,
so thanks, Gary. So what I'll do is I'll facilitate the questions. Steve, just when I look at the chat, I don't know if it's on your side, it says that the chats are disabled. So I don't know if you're able to deal with that.
No, so I did check. The setting is set for chats, so I'm not sure why it hasn't come up.
Okay, so Gary, I've got a few questions. So what we can do is I've got a few questions that I've collected this week, and then after that, because the chat doesn't seem to be working, if anyone's got questions, you can just unmute yourself and go ahead with the questions. So Gary, the one question that came up quite a bit is with regards to the vaccination. The news that is coming through is that kids under the age of 18 will not be receiving vaccinations. The question is that correct? And how do we deal with our teenagers whose bodies are more adults than children, and whether it's necessary?
Okay, so I mean, there's a lot to unpack in that question. So firstly, by and large, the way the vaccines are being rolled out is with an eye on where can they provide the most benefit, and part of that relates to, well, how have they been studied? So based on the data that have been released on all of the vaccines, the trials have, with one exception really, have only enrolled adults, so people from 18 years and up. Some countries have extended that lower age limit to, at this stage, to 16 years and up. And there are trials around the world that have now started enrolling younger children. And that's often how things are with medication, where you're dealing with a disease that affects adults and children. It's often tested in adults, and then slowly kind of the age range is broadened. So at the moment, there's studies enrolling children down to 12 years of age. And then once that data becomes available and it's shown to be safe and effective, when I'm saying effective, it'll almost certainly for them be looking at their immune response rather than their protection against disease. But once that happens, then the likelihood is that it will be extended to younger ages. So coming on to, well, what is the aim of vaccination right now? While we're in the early stages, while we have relatively limited vaccine, and while the vaccination coverage is essentially zero, is the idea is you want to be covering those that stand to benefit most from the vaccine. So even if we had lots and lots of vaccines right now, and even if they've been shown to be effective and safe, in all likelihood, children would not be anywhere near the top of the list to be receiving the vaccine, because they, while they may get some benefit, and if the various vaccines are eventually shown to reduce transmission, which hasn't as yet been shown, but which is likely to be the case. But if it's not, they wouldn't even really stand to benefit much at all from vaccination. So the idea being, with at the moment, while we have limited vaccine available, and while we have a program that is obviously going to take time to get up and running, the idea being to vaccinate healthcare workers, so that they're at, not that they're so much at high risk of significant disease, but the healthcare workforce, if it were to be affected again by large numbers being off sick for long periods of time and in quarantine after exposures, you don't really want that to be the case if and when additional surges come. So they've been prioritized, and obviously children aren't part of that group. And then the next priority groups are going to be those with significant risk for severe disease. And again, that wouldn't apply to children. So that's going to be the elderly, it's going to be those with significant pre-existing diseases. And eventually, I suspect, if, as I say, if the vaccines are shown to interrupt transmission, and then the only way to kind of really get adequate, or so-called, what you hear people talking about, herd immunity or indirect benefit from the vaccines, where you need very high levels of population immunity, and that would potentially involve children. That would kind of be the time when the vaccines would be likely to include them. So long answer to your question, but right now, children would not be a priority, both because they are not at substantial risk for severe disease, and there are lots, millions more people who stand to benefit far more than a child would from any of the vaccines right now.
Thanks, Gary. Another question that came up is the new strain that has come, that they call the South African strain, seems to affect much younger parts of the population. Has there been a rise in this statistically of children being infected and admitted into hospital with the new strain?
So the variant that you're talking about, the one that was first described in South Africa, and certainly what you're saying is what many healthcare workers have seen, not with respect to children, but with respect to affecting younger adults. The data that are available for South Africa at the moment actually don't seem to bear that out. They seem to suggest that the age profile is largely similar for the second surge, which is almost all the new variant, compared to the first surge, which was predominantly the original variant. And so it doesn't actually seem that there's a substantial difference in the age profile between the two surges. And the same also seems to be true with respect to the disease severity amongst younger people. So it's a difficult. It's not. It's somewhat difficult to understand why people's impression is quite different to what the data are showing, and there are a couple of possible explanations for that. And this is a little bit different, I think, to what's being seen in some of the European countries, where they potentially are seeing a slightly lower average age of patients that are being admitted. But that may well be because of other measures that are in place that are kind of protecting the elderly from exposure. So certainly from the experience in South Africa, from the data that are available, and from our hospital, the second surge has barely made any difference to our admission numbers. The kids that are testing positive are often being admitted with things that are completely unrelated to COVID, and we can't even. So, for example, in the adult setting, when someone's being admitted, it's not that difficult to kind of predict which are going to turn out to be COVID positive and from those that are COVID negative. Whereas in our wards, it's completely by chance. So what I'm essentially getting at is, even though they've got disease that's something wrong with them that makes them sick enough to warrant admission, that almost certainly has got nothing to do with COVID. And even when you pick up the COVID in them, it's incidental. It isn't what was making them sick. Well, I was going to come on to kind of this inflammatory condition that people may have heard of in kids, but maybe we'll just leave that for now, other than to say that we have seen it. It is serious. It is very, very rare, and we've seen much less of it with the second surge, although it may be too soon to say that because it's something that kind of follows on after the peak. It's more of a post-infectious phenomenon than anything else. So in summary, yeah, we're not seeing, and neither is the data that's coming out of this country or most other countries, suggesting that children and young adults are being affected more commonly or more severely with the current strain that's circulating.
Another question is there such a thing as a mother-to-child transmission? So like with HIV, can a baby in utero be born with corona if the mother has it, and does that affect the baby's lungs or anything in the first few days of life?
Okay, so again, there are gaps in our knowledge, but as best as we can tell, there are very, very rare instances where it's a difficult thing to prove, but where it seems somewhat convincing that there has been mother-to-child transmission. But we're talking about like about a handful of cases in a good few 100,000 women who've delivered babies while they've been COVID infected. So, for all intents and purposes, no. There's no significant transmission from mother to child in utero. Babies can be infected by their mothers after giving birth. And again, there's a lot we're still learning about it, but the vast majority of those babies that do get infected, either from their mothers or from someone else as newborns, don't get severe illness. There are occasional exceptions to that, but again, the general rule would be that they don't get particularly ill with the disease at all. We kind of in the process of revising recommendations around testing them, because before we knew what we know now, we were recommending quite a lot of testing for babies born to COVID-infected mothers, and the recommendations around that, both in South Africa and elsewhere, is to do much less, if any, testing, unless they actually get sick, because the chances of them having anything serious is really very, very small. A related question to what you're asking is the effect of COVID on pregnant women, and that is something that is turning out to be, not unsurprisingly, and it's not necessarily a huge impact, but pregnant women who have COVID are at somewhat higher risk of giving birth to premature babies and experiencing a few other obstetric complications. But even so, the vast majority of them have relatively mild infections, again, with some exceptions, and certainly a little bit more in them than in their babies.
So I've just had a question sent to me, and I'm just going to read it. Have there been any severe cases of COVID in kids where the kids have had no pre-existing conditions?
So, okay, I mean, certainly to reflect on my experience, the answer is no. We've had from a pure COVID point of view, I'm not talking about the post-inflammatory PIMS or MISC that people have heard of, where you do get very severe cases. Our experience is we haven't had anybody with acute COVID that's been anything other than mild. Looking at the experience elsewhere, and it really is quite difficult to always tease out, because kids get sick, and previously well kids can get very, very sick from infections and from other things, and inevitably, if there's lots of COVID in the communities, kids like that will test positive. So teasing out how much of it is related to COVID and how much of it is related to whatever else is going on with them can be very challenging. But certainly the experience from around the country and from elsewhere in the world is that the vast majority of kids who have severe disease have at least one other pre-existing condition that puts them at high risk, but there are very occasional cases of severe disease in completely previously well kids, but it's really small numbers, not to the extent that any kind of one hospital or clinician is going to have seen more than a handful of such cases.
Another question sent is, I've heard that Israel has started vaccinating children. What's the story there?
I don't know exactly how they've expanded their policy, so that may well be true. I can't say for sure. If anyone else has more accurate information, I'd be interested to hear that. If so, it would be based, as I said, they're going into an area which has not yet been well studied, which I'm not saying is wrong, because there's no reason to think these vaccines would be unsafe or ineffective. But it would be something that hasn't been adequately studied at this stage, although those data are expected in the next few months. And if they were doing that, it would probably be with an eye to trying to get at least kind of 60 to 80% of their total population vaccinated, so that they can start getting the indirect benefits for the non-vaccinated proportion of the population to potentially start benefiting from reduced likelihood of getting disease because of high levels of vaccination in their communities. But specifically, if that's what they're doing, I don't know about that yet.
Okay, another question with our kids going back to school. When do the experts feel that extramural activities with contact sport can start? Soccer and rugby and netball.
Yeah, I mean, the whole school issue obviously is one we haven't really touched on yet tonight, and it is a contentious one, and it is quite an interesting one, and again, it's an area where we're learning. I think from the data that are available, and certainly looking at the country as a whole, the benefits of having kids, certainly pre-primary and primary school kids back at school, the benefits dramatically outweigh any potential harms to the children, and provided the teachers are doing what they're supposed to be doing, the risk to them should be minimal. That risk is a little bit higher around the world in high schools, but even so, the benefits for South African kids are substantially greater than the potential harms, and probably the same with respect to universities, but there it does get a little more complicated around residences and things like that. Specifically around sports activities, and you need to differentiate what sports activities you're talking about. So something like, and I know the question relates to contact sports, but something like tennis, where there's large distances between people involved, it's outdoors with good ventilation, that would be incredibly low risk. Then extrapolating that to slightly less, not really less safe, but certainly where there's more contact between them, again, if they're if they're outdoors and they're largely conscious of what's going on with respect to their activities, the risk is relatively low. Is the risk zero? No. I mean, we can't say that. Would I be comfortable having my teenage son, for example, going into a scrum, if they're a front row forward in a scrum right now? I'd say probably not. Would I be comfortable with them playing goalkeeper on in a soccer match? Probably yes. With respect to cricket, where there's less contact, I'd say that's probably fine. Netball might be somewhere in between. So it's not. I mean, I know it's a kind of a long answer, and I may not even be giving you a kind of a good direct response to your question as to when it'll be safe. But certainly when community transmission is relatively low, we're talking about low risk people in a fairly low risk setting. I think the risk of anything significant happening from acquiring COVID during a sports event like that, I think would be relatively low. For me, the real concern would be, for example, if you've got a whole sports team in a vehicle all traveling together without open windows, that's when they're potentially going to get infected traveling to and from the games, rather than while they're on the sports field itself.
Another question is, at the outset, when there wasn't much information, children were considered to be what we call super spreaders. Is that still the case with regards to children? And I know they can get COVID, and very often they don't even show symptoms, but are they still super spreaders like with the flu?
So no, at no point were they ever considered to be super spreaders, and that hasn't changed. From the start, it's been recognized that their chances of them making anyone else sick were certainly no higher than an adult. In the beginning, we weren't sure whether it was the same, so whether they would be just as likely to transmit the virus as an adult. We now know that they're much less likely to transmit. And some of the data in this area are a little confusing, because there are a couple of studies that have actually found large amounts of virus in mildly symptomatic and asymptomatic children in their nose and throat. And the fear was that that would mean that they would pose a risk to the people around them. And it hasn't turned out that way. I mean, other studies haven't found that they've got such high viral loads. And even those where they have, and it doesn't seem like they're an important route of transmission, the thinking is, well, if they're not sick, the fact that they're not coughing and they're not therefore creating as many infectious particles is probably the reason why they don't seem to pose much risk to the people around them. Not to say that risk is zero. I think in the very young kids it may be fairly close to that, but in older kids and certainly symptomatic kids, that risk does exist. I would think, again, the data are not yet completely clear on that. But in any event, it's still substantially less than for an adult in a similar situation. And no, there's absolutely no reason to think that any child has been a super spreader. There's that hasn't been reported as far as I'm aware.
Okay, are there any questions that haven't been sent to me? Anybody wants to before that, I've got a nice question. Is it safe to hug grandchildren? We were initially told to stay away from them.
I mean, obviously, for all of these sorts of things, you have to weigh the risks and benefits. And for grandparents not to have contact with their grandchildren for a year is harmful. I mean, there's no getting away from the non-medical harms related to that. But the recommendations remain the same, is that as far as possible, we want people to be avoiding unnecessary social encounters, particularly with respect to coming into contact with high-risk individuals. And for many grandparents, they're simply based on their age going to be high-risk individuals. So is it unsafe for a grandparent to hug their grandchildren? Potentially not, but it's still something that as hard as it is something that we would want to minimize as far as possible. We because we can see how serious the disease is in the elderly. So even though the risk of them acquiring a disease from a young child is relatively low, if it's something people are going to be doing, it needs to be done very cautiously, short periods of time, outdoors, with masks, and in those sort of settings, it probably would be fairly low risk, but not zero risk. Certainly not for example, for an adolescent grandchild. Maybe for a young infant or a preschool child that would where the risk is substantially lower, that would be a reasonable consideration. But it's a difficult area because we really do need to be looking after our highest risk individuals.
Anthony Rosemarin has a comment, if he could just unmute himself.
Yeah, hi, thanks, and thanks, Gary. Just on the question about Israel, Israel definitely are vaccinating youth. I know of 15 and 17-year-olds who are vaccinated today. So it is happening, and I think the reason is that what you're finding quite a high rate of refusal to take the vaccine in Israel, or to have the vaccine. So I'm sure this is exactly what you were saying, Gary, in that they are trying to reach that 60 or 70% to hit herd immunity, and that's why they're now spreading the vaccination to different population segments. So yes, but it definitely is happening.
Yeah, no, certainly I'm aware going down to 16, but if you're saying they're going younger than that, yeah, I'm interested to hear that. Thanks, Anthony.
Another question that's been sent to me is it dangerous or risky to allow cousins and aunties and uncles to hold a 5-month-old baby?
It essentially comes down to the same principles that come into making the decision around the grandchildren and grandparents coming together. If it's avoidable, then it's probably best to avoid it. If the decision is that the potential benefits might outweigh the potential risks, then to do it as safely as possible. There's no I'm not worried about the baby in that setting. I'm potentially be more worried about the parents of the child also being in the same setting and transmitting to the uncle or vice versa. So I'm not worried about the baby making the uncle sick, and I'm not worried about the uncle making the baby sick, but I would be worried about the rest of the adults in that setting.
Sorry, Gary, there is one
No problem.
more here. How effective is the vaccine? So, for example, just using, this is a question that came from Israel, but for example, using my circumstances, my mom in Israel has received both vaccines. 2 weeks have passed since she's received the second dose. Can she now come visit South Africa and see her grandchildren?
So again, there's a lot that goes into answer the question. There's a fair amount we know and a fair amount we don't know about the vaccine. So if she's already received 2 doses, then essentially what she would have been received is 2 doses of one of the 2 mRNA vaccines, which we know protect somewhere in the region of 95% of their recipients 2 weeks after having received 2 doses against the original variant. How much protection it would provide against the strain that's currently circulating in South Africa is somewhat unclear. From immunological studies, certainly a couple that have come out in the last day or so, it suggests that those vaccines, again, we talk about lab studies now, so which may or may not translate into real world protection, do provide some protection, but it is not as much as against the new variant, but it's not as much as against the previously circulating variant. So what most people think, and again, this hasn't yet been proven, is that the currently available vaccines will provide a fair amount of protection against the currently circulating variant, the variant circulating in South Africa, against severe disease, admission and death, even if it provides less benefit against less severe manifestations. And again, these are not necessarily proven conclusions, but it would seem to be that way. But will it be less than the the effectiveness against the original strain? Probably to some extent, but still it will provide substantial protection, we think, against important serious outcomes, and certainly much more protection than having received no vaccine at all. So in answer to the question, would it be safe for her to travel here? Again, the same sort of principles apply. Yes, in all likelihood it would be, but provided she would still be recommended to use her mask when she's around people, when she's out in public. The recommendations around physical distancing and hand sanitizing would remain in place, because there's, as good as these vaccines appear to be, none of them are ever going to be 100% effective, and people in that sort of age group, if they do get sick, are at high risk, at very high risk. So it comes down to the same sort of thing. Do the benefits outweigh the potential risks? And if you make that decision for yourself and are happy to bear the consequences, then it may not be unreasonable.
A question about logistics. How do parents deal with lift schemes to school?
Yeah, it's a fair question, and it comes down to those principles that I was kind of touching on with respect to the sports team in the bus going to and from a sports event. If it can be avoided, it's probably best to avoid having kids, certainly older kids, in close contact with each other for long periods of time in an enclosed vehicle. If it can't be avoided, then everyone, driver and all passengers, should be using their masks the whole time. The windows should be open, because ventilation is an absolutely vital component in reducing transmission. So the car window should be open regardless of summer, winter, rain, whatever, if you want to try and drop that risk of transmission right down. And even then, I mean, you're going to have people well within a meter and a half of each other for that time. But if it's a large vehicle and they can be spaced out, they should be. So I know I'm repeating myself, but again, it comes down to the family doing some sort of risk-benefit calculation and deciding whether the benefits to going back into a lift scheme outweigh the potential harms. The potential harms are probably low, provided that all those measures are in place, but they're going to be higher than if the members of the household kind of kept to themselves. So each family is kind of going to need to decide that for themselves. Sorry, go ahead.
Another question, not necessarily about children and COVID. It says, would Gary please share his views on ivectomine, both as a prophylactic and treatment? I know it's extremely controversial, so hand it over to you.
Sure. I mean, I don't want to spend too much time on it because it is a fairly prolonged discussion, but it's only it's largely controversial in this country, whereas if you look at the issue of ivermectin around the world, it's not even on the radar of most other countries. They just don't even think it's got any real likelihood of providing substantial benefits. There's small pockets around the world where it seems to be topical, and South Africa is one of them. We don't have answers to the question. The studies that have been published and are out in the public domain all have substantial problems with them. Even when you start putting the studies together and try and analyze them together, those publications are largely based on data that have not been properly reviewed and published in the sort of kind of mainstream way. Those so-called systematic reviews and meta-analyses are being done by the authors of the original unpublished studies, which has real scientific questions around it. It's unclear even what the possible biological mechanism would be for ivermectin to have benefit. So for me right now, I don't even think it should be a consideration. Until we have compelling evidence of benefits. And some of the studies are interesting, but until we have compelling evidence of benefits, I think it would be inappropriate to routinely recommend it, and we haven't. Some of those things I've started presenting on way back in the beginning, my second or third slide, were our national guidelines on that. And it gets even more scary if you look at what some of the data coming out of the UCT pharmacology lab towards the middle of last week, where they were asked to analyze some of the ivermectin preparations that have been brought into the country, unregistered, from a variety of places around the world, and 80% of those samples that they analyzed contained a variety of other ingredients. So even if the ivermectin itself was safe, and it would appear to be a safe, at least with respect to, it's got a good safety record over a number of decades. So safety seems to be less of a concern. But if you're taking the medication, you're not, in all likelihood, taking only ivermectin. You're taking something else with it. And I mean, there were all kinds of other things in there. And whether that was deliberate or whether it was just poor manufacturing, we don't know. So even if it were shown to be beneficial, and that, for me, I think that's a big if. Even if it were shown to be beneficial, you'd want to be using a registered preparation from a recognized supplier. And what's currently available in this country is not that. So yeah, and that's the short answer. We could go into a lot more detail about those studies, but there are real major concerns around them. And believe me, as clinicians, we would really like to have something to offer our patients that will make a substantial difference to them. And if it does work, then we need to know that. But right now, we have no real idea whether it works or it doesn't, and we don't know whether. I mean, I said it's safe, but certainly at some of the doses that are being recommended, those haven't been well studied. So there are some safety concerns still. So the short answer to that question is no. As of now, ivermectin does not seem to have a role in either prevention or treatment of this disease until we have better data.
Those are all the questions that were sent to me. Are there any brave souls that want to ask Gary questions live? Please unmute yourself.
Are people able to unmute? No? Are people able to if they want to? If you're not hosting?
I hope so. Am I host?
Yes, you can.
You can
There we
definitely
go.
unmute.
Yeah.
Okay, there.
Can I ask another question?
Sure, go for it.
Have you seen a big impact psychologically with kids with regards to COVID? Not necessarily kids who have been infected, but just the effects of the change, the no contact, the distancing, no school. Has that been a big issue?
So I mean, absolutely, it is a big issue. It's not necessarily one that's going to result in a child presenting to hospital. So I'll show you what I've got on the slide coming up now. But it's, I mean, if you're looking around the country, if you're looking at a large number of certainly adolescent psychiatric diagnoses are going up. Adolescent suicide attempts are going up. I haven't seen any South African data on this, but where there are data coming up from around the world, certainly those numbers seem to be going up. What we're seeing in our setting is certainly far more children presenting with other vaccinations that are not up to date, where they either haven't been able to access vaccines because of the lockdown, or they've been too scared to go to the clinics to get the vaccines. We're hoping it doesn't happen, but we are already concerned that some of the vaccine preventable diseases that were uncommon prior to lockdown are not going to become more common. But it wouldn't be a surprise if we started seeing outbreaks of some of those. From a nutritional point of view, we've seen certainly an increase in malnutrition in kids who particularly kind of preschool and early primary school kids where their best meal of the day would be the one they get at school, which they now, for the best part of the last year, haven't been able to get. So we've absolutely seen that. In kids being newly diagnosed with malignancies, it's anecdotal, but certainly our impression is that they're presenting with more advanced disease than it would usually have been the case. So again, either people not realizing what's happening because they're only in contact with their parents, so kind of other adults not really picking up on their symptoms, or their caregivers feeling like they're in some way scared or nervous to access healthcare. So certainly our impression is we're seeing kids presenting with more advanced disease as a result of lockdown than they would have in the past. And one of the major concerns, again, it hasn't yet manifest, but it certainly may well, would be around things like tuberculosis. Having kids in home all the time with poor ventilation, poor access to services, it wouldn't come as any surprise. And one of those publications I showed you was kind of how the TB diagnosis dropped off dramatically during lockdown, not because they think TB was less common in children, but because accessing diagnostic services dropped off dramatically. So yeah, I mean, and that's kind of what we were getting at earlier about the harms of keeping schools closed for kids in South Africa. And I'm phrasing it like that because I think the vast majority of kids in this country are not necessarily the kids of the parents on this call. We're talking about kids who are in poor areas where nutrition is a concern, where there's very little access to things like Wi-Fi, internet, and so they essentially lose a year of schooling, and the potential harms of that are huge.
Sure. Thanks, Gary. Pretty scary.
Yeah. So no, I had just.
Oh, there is one. Sorry, can I ask?
Yeah.
I've just had a question that was sent through to me.
Okay.
Is there any understanding why children are protected from severe disease?
Okay, so well, what I was about to say was I had just in preparation in case we didn't have enough questions, I kind of jotted down a couple that I commonly get asked, and that was the top of the list. Again, the short answer is we don't yet know completely. There are lots and lots of theories, some of which make more sense to me than others, but it's got to do. I mean, and if I'm going into too much detail from a biological point of view, I mean, just someone can say so. But the first theory is that the receptor that the virus uses to get into the human cell is much less. There's much less of it in the upper airways of children compared to adolescents and adults. And as people get older, there are more and more of those receptors. So the virus may find it more difficult to infect children. Also, another one of the theories is that children often have lots and lots of other viruses in their nose and throat, either making them sick or just kind of hanging around. They're not doing a hell of a lot. And so there may be more competition between those viruses and coronavirus when it's introduced. And so again, it's less likely to infect. There do seem to be important differences in the immune response between how children's immune systems react or respond to coronavirus compared to how adults and particularly the elderly do so. And that also seems to be an important component. And again, as I say, we're still learning about a lot of these things, and it'll probably turn out to be a combination of factors. But it is still quite kind of an area which, as a pediatrician, we're thankful. But to say we have a complete understanding of why it's so much more severe in other age groups is something we're still learning. Should I just go through my other things that I thought of and just see? We've spoken about these. It seems to be less of an issue now, but certainly early on when masks were being recommended, there was a lot of interest in face shields, and are they equivalent to masks? And the short answer to that question is no. They potentially adds a little bit more protection to, in addition to a face mask, but they absolutely are nowhere near as effective as a face mask by itself. But the combination for a child may have some small additional benefit, but it's not something we're recommending. Around schools, we've spoken a lot about that. So certainly, I think I've been quite clear on that, provided it can be done safely, and that's got to do with the changes that need to be made at the schools. And we absolutely need to be protecting our teachers. And I think they should be prioritized as probably very soon after healthcare workers, amongst the top of the list of people who should be offered vaccines. But the potential harm of school closure, and I've listed some things there. I think we've touched on most of those: nutrition and mental health, and physical health, and social and financial. Financial, what I'm getting at is in many households, not having children being able to go to school means parents can't go to work. So it's got real financial implications for households like that. So I think, yeah, provided it can be, I think it's, I mean, I've said this, some of the people on this call have heard me say this often, is that in when countries are considering lockdowns and what to close and what to reopen and when to do it, in my view, schools should be the last places to close and the first places to reopen. And so to all intents and purposes should remain open throughout. Again, in a country like ours, I think in another setting where internet access is better and in-person teaching may not be completely necessary, I think you can start to make a different argument. But for our setting, for me, it's a relatively straightforward decision. The potential harms to our children just grossly outweigh the benefits of keeping them out of school. The question of when to close, and we don't have good answers to that. The Department of Basic Education has got guidelines they've drawn up as to when schools should close. The view certainly within the Pediatric Association is hardly ever. And if the schools are doing what they should be doing properly, even if there are significant numbers of cases in a class, then it may be reasonable to close or to keep that class at home for a period of time rather than closing the whole school. But even that is seldom going to be necessary. And the question of vaccination, I think you touched on quite a lot. And I think then, yeah, the questions that have come up have largely been the questions I was expecting. So if people have any additional questions, either now or at some point in the future, that's meant to be a coffee shop with an open door. So they're welcome to give me a shout, drop me a message, email me, and I'm happy to try and answer people's questions if I haven't covered it now.
Can
Gary,
I ask?
one-
Oh,
sorry.
you go first, no? And then I've got one that's been sent to me as well. Go first.
Okay, so before we thank you and we do the lucky draw, and I see that we're getting quite late, but it's obviously been a very popular topic. I've got a question from a teacher. She says, as a teacher, do we need to wear masks and shields around kids who don't wear masks? We've been asked to wear both in classroom, not just the mask, because kids from 2 to 3 years old don't wear masks.
Yeah, so kids, I mean, young kids, and so what we're recommending in this country is kids under 5 to 6 years of age. We're not recommending masks for them. They don't keep them on. They end up touching them in their faces more than anything else. And we don't think that they pose significant risk to the people around them. So for them, as best as possible, physical distancing is appropriate, hand hygiene is appropriate. The people we really want to be protecting in that setting are the teachers. So absolutely, teachers must be wearing masks and with good adherence to that. So yeah, masks with respect to face shields, as I kind of touched on, they do provide a little bit of extra benefit. So if the teacher's comfortable to doing so, and they can teach effectively with both a mask and a face shield on, I think it's reasonable. Should it be compulsory? No, I don't think so. I don't think it adds enough additional benefit to a kind of properly fitting mask to kind of justify the discomfort and how it kind of gets in the way of many teaching activities. But I mean, my view on that is not necessarily the only view, and each school will need to make those sort of decisions for themselves. It's certainly not national or national policy or anyone's policy that I've seen, beyond maybe a particular institution, that teachers need to wear both masks and face shields. But if that's the decision the school's taken, I mean, they certainly have the ability to make those decisions for themselves and their teachers.
There was just one more question that came through, and it's not specific to children. If you have had corona, what is the percentage of getting it again and getting the second variant?
Again, one of the areas that we're still learning, reinfections with, I mean, even before this particular coronavirus, people got lots, I mean, not lots, but I'm saying getting repeated infections with coronaviruses is the norm. So it shouldn't come as any surprise that reinfections with this coronavirus occur. We're kind of learning about the immunity that is given by the infection of the virus, and there's fairly good evidence to suggest that at least 3 months and probably at least 6 months of immunity is conferred by infection to most people infected. But there are lots and lots of people getting reinfected, and that's what I mean. That's kind of from an evolutionary point of view what we can expect is the virus will mutate to avoid or kind of get around the immunity in a particular population. And that's what we're kind of seeing happen. It doesn't come as a surprise. So the fact that people can get reinfected with the currently circulating variant won't come as a surprise, and in all likelihood will continue to happen with future variants. By and large, there are some exceptions, but by and large, subsequent infections seem to be less severe than the initial one. So your first infection seems to be more likely to be serious than your second one, but there are some exceptions to that. And the same would apply to kind of post-vaccination, is we don't necessarily know how long-standing vaccine immunity will be. It's something we're going to learn about. The view is that it should provide fairly long-lasting immunity for serious disease, but whether we'll need to have boosters in annual vaccines, different vaccines, all of those things we'll learn with time.
So, Gary, I've got one more question coming from Israel, and I think we'll make it the last question because it's getting late. And if people are interested, we could maybe do a Corona and Kids version 2. If there's more questions, we can try schedule another one. So the question is, with facial expressions key, especially in teaching younger ages, until when will teachers need to wear masks?
I wouldn't be comfortable making any sort of prediction. It's a real issue. I mean, there's no getting away from that. I mean, I'd hate to be a child who's kind of going through the kind of early childhood development years, kind of those preschool years, in this sort of setting where they're losing out on all those forms of stimulation. When will it happen? I would like to think that once we have high levels of vaccination in place, and we know that vaccine-induced immunity is robust, that we could probably start thinking about that. But I'd be guessing maybe, I don't know, early next year at the earliest. But that's a fairly kind of optimistic view. Sorry, I wish I had a more kind of a better prediction or more confident prediction, and that it was sooner. But I don't think that's likely to be the case.
Okay, so I just want to thank you, Gary, so much, and you putting on your email and your cell phone number is really, really very generous of you, and we really thank you for your time and the effort that you put into this with your slides and everything. So thank you for making our coffee club, our first coffee club of 2021, so exciting. And I'm going to pass it on to Aideen, who's going to do the draw, but before I do, I'm going to divulge to everybody what our prize is. So I hope you can see it. This is basically a deluxe Vanity Fair bag, and it includes a lavender lather body wash, a velvety soft body lotion, helping hand waterless hand sanitizer, and a velvety soft hand lotion, together with a nail file. So if the winner is a gentleman, I'm sure that they've got a lovely lady that they would like to give it to. So I'm going to sign off. Thank you again, Gary, and passing it on to Aideen.
Thank you, Noah. So I've got Mixie here who is going to do the random number draw. Okay, Mix, go for it and then call up the number. And I've got everybody's names. Number six, and number 6 is Marion Hollander. It's yours. Mazel tov. Great. So just thank you everybody for being here and for supporting us. First one of the year. Looking forward to another year of wonderful coffee clubs. Good night, everybody.
Hello, Mix.